Hello, my name is Megan Gillette. I'm a medical student here at Emory, and today I'm presenting on my project, which is a geospatial analysis of access to healthcare for children with disabilities in Kilifi County, Kenya. For this project, I had the opportunity to partner with Kupenda or Kuhenza for the Children, which is an advocacy organization for children with disabilities in the Kilifi County area. We were particularly interested in looking at access to healthcare for children that they serve or children within their network. And in fact, one of the goals in the Kenya Health Sector Strategic Plan for 2018 to 2023 is to expand access to healthcare services within a 5 kilometer radius of an individual's home to ensure that they have timely access to these healthcare services. So, in terms of a bit of background on the Kenyan healthcare system, there are 6 hierarchical levels of care delivery called the KEPH levels, ranging from level 1, which is the community level, level 2, or dispensaries and clinics, which provide basic outpatient care, all the way to level 6, with higher levels providing more and more specialized care. And so this study again aims to explore the locations of some of these public health facilities alongside the locations of children in Kupenda's network to attempt to understand access to healthcare for these children in Kupenda's network. And so I began by taking an existing geolocated list of public health facilities in sub-Saharan Africa, and I updated it to be consistent with the current version of Kenya's Master Healthcare Facility List, which is maintained by their Ministry of Health. I then received coordinates of children living in 4 out of the 35 wards in Kilifi County, Kenya, from Kupenda, which was used in the study. And those wards were Dabaso, Gonda, Kakayuni, and Watamu wards specifically. And using ArcGIS Pro, I ran buffer analyses using buffers at 2.5, 5, 10, and 20 kilometers, which are essentially concentric circles or radii around each healthcare facility. And then I calculated the number of children living within each radius of a healthcare facility to attempt to understand geographic accessibility. My results are shown in this middle panel here, alongside all of the visualizations that I made for this project. So you can see in this map in the top left corner all the public health facilities in Kilifi County that I included in this study. You can see that many are concentrated around the coastal areas of the county. Level 2 facilities shown in blue are definitely more abundant in number than level 3 and level 4 facilities shown in green and red respectively. Also, major and secondary roads are highlighted in this map alongside a major river that runs through Kilifi County. In terms of the buffer analysis, for level 2 facilities, I found that 99% of children lived within 5 kilometers of a healthcare facility or level 2 healthcare facility, meeting the Kenya Health Sector Strategic Plan goal that was set forth. For level 3 and level 4 facilities, however, coverage was different. 34.9% of children lived within 5 kilometers of a level 3 facility, and 47.6% of children lived within 5 kilometers of a level 4 facility. I also looked at facilities specifically of these that offer PT and OT services, and I found that 45.64% of children lived within 5 kilometers of one of the 6 out of 9 facilities that I was able to geolocate of the facilities that were identified to me as offering these services. So definitely expanding access to PT and OT or higher level healthcare services is helpful to ensure that children have timely access to the healthcare services and healthcare facilities that they may need. Some limitations include the exclusion of healthcare facilities that I could not geolocate and potential inaccuracies of the master healthcare facility list or list of facilities I used. And future work should explore different wards beyond what I explored, access to private healthcare facilities, and access to specific services offered by each facility. Thank you so much.
Hi, my name is Margot, and I'm excited for the opportunity to share my findings on the real-world outcomes of lutetium PSMA 617 within a racially diverse cohort conducted at Emory Winship Cancer Institute. Prostate cancer outcomes have historically demonstrated significant racial disparities, particularly affecting Black men. According to the American Cancer Society, the average annual incidence rate of prostate cancer is 73% higher within Black men compared to white men. Furthermore, Black men are nearly twice as likely to die from their prostate cancer compared to their white counterparts. To address these disparities, it's essential to evaluate novel therapies like lutetium PSMA 617 within diverse populations. Lutetium PSMA 617 is a novel radioligand therapy that delivers beta particle irradiation to PSMA expressing cells. It's shown promising results within the treatment of metastatic castration-resistant prostate cancer. However, the pivotal trials in which lutetium gained its FDA approval had only 6.6% inclusion of Black or African American patients. Our real-world analysis at Emory is the most diverse patient cohort in which lutetium PSMA 617 has been studied to date. In our cohort, 40% of patients self-identified as Black and 44% self-identified as white. Our primary study endpoints were overall survival, progression-free survival, as well as PSMA 50 response rates. Our results showed that Black patients had a significantly higher initial baseline burden of disease. Black patients had higher prostate-specific antigen, as well as higher alkaline phosphate, indicating greater bone involvement. Our findings showed similar overall response rate, as well as progression-free survival. Non-white patients had slightly higher PSMA 50 response rate at 59% compared to 50% in white patients, although this was non-significant. This real-world evidence underscores lutetium PSMA 617 effectiveness within real-world diverse populations. With similar treatment response rates, despite a greater baseline burden of disease among Black patients, our results underscore the importance of expanding access to novel therapies such as lutetium PSMA 617 in order to close gaps on prostate cancer-related health disparities. Our study demonstrates that advancing health equity requires ensuring diverse representation within clinical trials and analyses, and the importance of expanding access to make steps towards achieving health equity within prostate cancer. Thank you.
Hello, everyone. My name is Rosalind Bird. I'm a categorical internal medicine intern, and it's my pleasure today to discuss Be Explore. Trans and gender diverse people experience discrimination in multiple aspects of life that negatively impacts their physical, mental, and sexual health. Despite the prevalence of HIV and other STIs being disproportionately high within these groups, certain members of this community continue to be underrepresented in sexual health research. And so accordingly, we sought to understand the barriers and facilitators to trans and gender diverse people participating in sexual health research. We utilize parallel convergent mixed methods, which means that we simultaneously collected quantitative survey data and conducted qualitative interviews. For the interviews, 10 people representing each gender identity group participated in interviews. So 10 trans feminine, 10 trans masculine, 10 non-binary assigned female at birth, and 10 non-binary assigned masculine at birth people participated. Those interviews were then transcribed, coded, and underwent thematic analysis using a team-based approach. We had 31 trans feminine people, 36 trans masculine people, 50 non-binary assigned female at birth, and 24 non-binary assigned male at birth people participate in the surveys. And then our mean age on average was between 28 and 30 across each group. The majority of our folks identified as white. However, we also had representation of Black, African American, or African descendants, Hispanic and Latine, as well as Asian folks. And as an important note here, we had several people who selected multiracial. Barriers to participation that were reflected in both survey and interviews reflected structural inequalities, uncertainty regarding the effects of experimental therapies, and negative experiences within the healthcare system. Whereas facilitators included first and foremost compensation, again reflecting structural inequities and vulnerabilities experienced by many members of this community. Clarity that the research is geared specifically towards helping the trans and gender diverse community, as well as racial, ethnic, and gender diversity of study team members were also important factors that encouraged study participants to feel inclined to engage in research. So in summary, trans and gender diverse people are eager to participate in sexual health research, and it is imperative that if we are to address disparities, we prioritize the experiences of this community. We must increase participation through creating diverse study teams and inclusive protocols. And finally, we must work to address the structural barriers that limit trans and gender diverse people's access to HIV and STI prevention, as well as the research process. I would like to thank my PI for this study, Dr. Cassie Grimsley Ackerley, as well as our collaborator and the students that assisted with this project. I'd also like to thank the National Institute of Allergy and Infectious Diseases for funding this project. Thank you. I'm happy to take questions.
Hi, everyone. My name is Devin Fritz. I'm a third-year biology undergraduate at Emory University. I've been conducting research in the Mind and Heart Lab, which is under the Department of Family and Preventative Medicine at Emory School of Medicine, under the mentorship of Dr. Ambar Koshrestha since spring of 2024. Today, I'm presenting our study titled Association of Anxiety and Sleep Behaviors Among Adolescents. We explored how anxiety and sleep patterns shifted among ninth grade students across different phases of the COVID-19 pandemic, and how changes in learning environments like in-person, remote, and hybrid learning impacted those patterns. Here's some background information. Anxiety disorders now affect nearly 1 in 3 adolescents, with rates rising more than 10% over the last decade. And while we know anxiety and sleep issues are closely linked, these studies have looked at how those relationships change across pandemic-related learning disruptions, especially in underserved areas. Our research took place in Barrow County, Georgia, a semi-rural, low-income district. We surveyed a little over 1,100 ninth grade students, 54% of whom consented, during 3 phases: spring of 2020, which was in-person learning, fall of 2020, which was remote learning, and spring of 2022, which was hybrid learning. What did we measure? We looked at both anxiety and sleep behaviors using structured and validated survey tools. For anxiety, we used clinical diagnoses as reported by students and GADC scale, which is the Generalized Anxiety Disorder Criteria for Children. A GADC score of 2 or higher indicates elevated anxiety symptoms. For sleep behaviors, we focused on 4 areas. First was sleep disturbances, which is trouble falling or staying asleep. Second was sleep duration, which was calculated from reported bedtimes and wake-up times. Third was social jet lag, which was the gap between weekday and weekend sleep patterns. Fourth was daytime sleepiness, which is how often students felt tired during the day. These were measured using tools like the Cleveland Adolescent Sleeplessness Questionnaire, the Ask Suicide screening questions, and additional self-reported questions. Our analysis used logistical regressions to calculate prevalence ratios, adjusting for gender, race, ethnicity, and socioeconomic status. Now here are the findings. Anxiety remained high across all 3 learning phases. 23% of students had a clinical anxiety diagnosis before the pandemic. 34 to 45% of students scored greater than or equal to 2 on the GADC scale, peaking during remote learning and staying elevated during the hybrid instruction period. We found strong associations between anxiety and poor sleep. Students with clinical anxiety were nearly 6 times more likely to experience daily sleep disturbances during the in-person learning phase. During hybrid learning, students with a GADC score greater than or equal to 2 had 19 times greater odds of reporting sleep disturbances. Interestingly enough, average sleep duration, daytime sleepiness, and social jet lag remained relatively stable across all 3 phases. This suggests that anxiety most strongly impacted sleep quality, not necessarily quantity. Why is this important? This research adds valuable insight into how mental health and academic disruptions interact, especially in semi-rural, low-income communities, which are often underrepresented in adolescents' mental health research. It reinforces the need for schools to monitor both anxiety and sleep and provide responsive evidence-based support during times of disruption. In conclusion, we found that both diagnosed and self-reported anxiety were consistently linked to poor sleep across different learning environments. By identifying these patterns early, schools and communities can better support adolescents' well-being and academic success. Thank you all for listening.
Hello, everyone. My name is Sam Chong, and I'm first-year PhD student here in Emory Nursing. I'm really happy to share our poster with you today. As we work toward achieving health equity, I think it is important to center the lived experience of people who have been marginalized. So African American families living with dementia face not only the challenges of the cognitive decline, but also long-standing effects of structural racism and limited inclusion in decision-making processes. Past research have shown that being involved in decision-making and having supportive relationship are strongly associated with the better quality of life for people living with dementia. But in reality, those people are often excluded from the decision making because of the assumptions about their cognitive limitations and due to dynamics within caregiving relationship. So in African American families where intergenerational bonds and cultural values of the respect and care play a key role, this raises a critical question. Even when a relationship appears positive, do people living with dementia truly feel like their voices are heard? That was the starting point of this study. So was a secondary data analysis based on a sample of African American adult daughter and parents' diets. Our analysis used only 33 diets with no missing data. For this analysis, we focus on variables reported directly by people living with dementia, including age, quality of life, self-rated health, perception of the diet and relationship quality, and perceived level of difficulty in having their opinions heard by family members. And we also included proxy-reported measure of dementia severity provided by their adult daughter. If you look to the right side of the poster, you will see some descriptive information about our participants. So we conducted regression analysis to examine the predictors of the quality of life. In model 1, we only included basic characteristics, including self-rated health. In model 2, we added diet and relationship scale on the positive interaction subscore. And in final model 3, we included the previous variables and added perceived difficulty in being heard. So key findings here was in final model, all 3 variables, good health condition, positive interaction, and difficulty in having heard by their family members were significant predictors of their quality of life. So what does this mean? Health status and relationship quality matters, but so does voice too. When people living with dementia feel unheard by their family members, it may impact their sense of autonomy, identity, and also their quality of life. So considering all these results, to advance the health equity for African American individuals living with dementia, we believe a dual approach is necessary. First one is we need to strengthen positive interaction within caregiving relationship. And also for the second, we need to actively support the voice of people living with dementia, ensuring their opinions are not only heard, but genuinely considered in everyday decisions. That's all for our presentation, and thank you for listening.